clinical dietitian at Aster Medicity, who I am sure will be providing us all the insightful tips in terms of how we can practically manage such conditions in our work. So all the best wishes to them, and I welcome them too. Next, I welcome all my team members who are part of A.E.D.A.N's office bearers, as well as the journal committee, the learning and the development committee, and the social media support teams, all of who have made this reality by in whichever way they can as a helping hand, and all the other A.E.D.A.N members and non-A.E.D.A.N members who have joined here physically, who are present, and all those who have joined online for making this a real nice and an informative learning session is what I feel. And last but not the least, the CNU is supported by Dr. Reddy's Nestle Health Sciences, and I welcome Mr. Prakash and the entire team of Dr. Reddy's Nestle Health Sciences for this CNU. Thank you and welcome all.
Thank you, Ms. Sindhu, for setting the tone of this event and the warm welcome. I would request the guests on the dais to please step down. We will move on to our first scientific session. Now it's time to dive into our first scientific session. The topic is medical management in Chyle Leak and the expected role of dietitians in the support system. Our speaker is the esteemed Dr.Fadl H Veerankutty, Senior Consultant Liver Transplantation and Comprehensive Liver Care, HBB Surgery at VPS Lakeshore Hospital, Kochi. I invite Ms. Hasina M.A., Executive Committee Member, Aedan, and ICDS Nutritionist Ernakulam to introduce the speaker.
Good afternoon, everyone. Our esteemed guests, my colleagues, my seniors. It's my honor to introduce our distinguished speaker, Dr. Fadl H Veerankutty, Liver Transplantation from Lakeshore Hospital. Dr. Fadl is a renowned expert with more than 10 years of experience in the field of liver transplantation and gastrointestinal surgery. He graduated from Calicut Medical College in 2005. He completed hands-on advanced training in pancreatobiliary surgery from the prestigious Dr. Rila Institute, Chennai, under Professor Rila, a pioneer in the field of liver transplantation. While working at Dr. Rila Institute, he gathered extensive experience in the pediatric liver transplantation and robotic donor hepatectomy. He is a reviewer for many reputed national and international journals and being invited by international medical journals to write expert reviews on various topics related to gastroenterology and hepatology. He has bagged many awards in various national and state level surgical conferences. His areas of interest are living donor liver transplantation, pediatric liver transplantation, and minimally invasive HPB oncosurgery. Today, Dr. Fadl will share valuable insights on medical management in Chyle Leak and expected role of dietitians in support system. Please join me in welcoming Dr. Fadl. Thank you.
Very good afternoon to organizers, and some faces are very familiar to me. So, coming to the topic, the medical management and the role of dietitian in postoperative Chyle Leak. So, I would like to start from the basics, the digestion of fat. And so, I'm sorry, this is a busy slide, but you can see how the fat is getting absorbed in the intestine. So fat is first emulsified by bile, it's form micelles, the small particles, and then these fatty acids are getting absorbed by the intestinal cells. This is a villi, microvilli of the intestinal cells, and these fatty acids are getting absorbed here. This, mostly these fatty acids combines with the phospholipids and the cholesterol and form chylomicrons. Especially this is the case of long chain fatty acid, and this enter into the intestinal cells and is transported to the lymphatic vessels. Why it forms chylomicrons initially before getting absorbed is that the long chain fatty acids are not soluble in the water. So to facilitate the absorption, they are getting united to the phospholipid molecules and also with the cholesterol and forms the chylomicrons, and these chylomicrons are getting absorbed into the lymphatic vessels. This is the case of absorption of large long chain fatty acid. But coming to the medium chain fatty acid, they are directly getting absorbed with the portal venous system, because medium chain fatty acids are water soluble. So they don't need any assistance of chylomicrons to get absorbed directly into the venous system. This is the basic of the management of the chyle leak. All of you should be very thorough with this picture. So moving to the chyle is composed of lymph plus chylomicrons. You know what chylomicron now, and this is basically an alkaline fluid. It contains triglycerides and phospholipids, cholesterols and proteins. And not only these nutrients, it's also contain bacteriostatic fluid. It's a bacteriostatic fluid. It's also contain immunoglobulins and fat soluble vitamins. And it contains around 400 to 6,000 white blood cells, mostly lymphocytes. That is very so this chyle has a very important role in the prevention of infection, in the immunity. So roughly 1 liter of chyle contains 200 calories of energy and around 20 to 30 gram of proteins, 5 and electrolytes. So this is our lymphatic system in the human body. So it contains lot of, you can see there are lot of lymph nodes. They are getting connected with the lymphatic vessels. So it starts from the toe, and this lymph reaches in the abdomen, and from the lymph also comes from the intestine, liver, and it forms the cisterna chyle. So this is the lumbar lymphatics, which drains lymph from the lower limbs, and all of it goes and unite in the cisterna chyle. From the cisterna chyle, this is a major lymphatic vessel that is known as thoracic duct. It drains into the left brachiocephalic vein and it reaches the blood. Okay. So this is the pathway of the long chain triglyceride absorption. So this is the portal blood circulation. This is the blood circulation. Don't confuse with the lymph circulation. So blood from the intestine mostly drain via the portal venous system into the liver. So all the nutrients like carbohydrates, protein are getting absorbed here, and it goes through the portal venous. This is a main portal vein. This is a systemic vein. This is splenic vein. Both join together and form the portal vein, and it drains into the liver. From the liver, all this protein, fatty acids, everything getting absorbed, and medium chain fatty acids getting absorbed and goes through the hepatic vein into the heart. That's how nutrients getting circulated in the blood. So this is the pathway of absorption of medium chain triglycerides. So how does the chyle leak? So it can be primary cause or can be a secondary etiology. So primary is congenital. By birth, people get, especially in the middle-aged woman. It's seen in the middle-aged woman. It's known as congenital lymphangiectasia. It's a inherited condition. Then the other causes are either due to obstruction or injury to the lymphatic vessels, or maybe due to infection, or maybe because of increased venous pressure, venous or lymphatic pressure. So the obstruction, most common cause is malignancy. Among the cancers, the most common cause is the lymphoma. And other malignancies like Wilms tumor, and can be due to trauma, can be a trivial trauma or can be surgical trauma. Especially in the abdominal surgery, mainly in the esophageal surgery, pancreatic surgery, in the liver transplant surgery, small bowel transplant surgery. These are the common cause in the GI tract. And coming to the thoracic surgery, again esophageal surgery or lung surgery or the neck dissection. Then can infection. This is one of the most common cause in the developing country, like tuberculosis or filariasis. And another reason is increased venous pressure. This is the reason why we get the chyle leak in the or chylocystitis in the cirrhotic patients, especially if they develop severe portal hypertension, they get the chylocystitis. And in some case of congestive pericarditis, back pressure from the venous outflow can cause chyle leak. So this can manifest chyle leak in the drain. Mostly in the postoperative chyle leak manifests in the drain. Mostly it is typically described as a milky white fluid in the drain, but it's not always true. Sometimes it be turbid. That especially happens in the liver transplant patients. Like they get a turbid fluid when we measure the triglyceride. This is the triglyceride level. It goes off, mostly it goes above 110. Then we diagnose is the chyle leak. So it can present in the abdomen either through the drain, or it can present as a collection inside. Or sometimes in the this urology patient, renal surgery, it can present as a chyluria. In the thorax, it can present as chylothorax. Okay, so it depends upon the location, the presentation varies. So if it leaks into the abdomen, the patient may get the abdominal distension. If there is a severe leak in the thorax, patient may get dyspnea. So the investigation is measuring the triglyceride level in the drain. It's mostly often above 110. So and the other investigation is ultrasound abdomen, or in the case of thorax, you have to do chest X-ray. And the ultrasound abdomen is mainly done to rule out the collection, because I told you it is a rich fluid of containing fat, protein. So it is a good nutrient for the bacteria to develop. So it's a focus of infection. You have to drain it. You should not allow it to collect. And then another investigation is demonstrating chylomicron in the drain fluid. This is a gold standard investigation, but we don't usually do it because the facility is not available in all institutes. Then what are the complications? What are the problem that you can get because of chyle leak? Obviously, the chyle is rich in lymphocyte, so lymphocyte depletion, and rich in immunoglobulins. So we lose all these immunoglobulins, and the patient is prone for infection. And the second one is nutrition related malnutrition. We are losing calories. The patient is losing protein and fat soluble vitamins, and hypovolemia, the loss of fluid. Some patients develop more than 1 liter. High output, we call it as high output chylous fistula. So they lose a lot of fluid and obviously electrolytes through the drain. And if it is getting collected, that can cause pressure on the vital structures. So you should keep all in your mind. Okay, you need to replenish the calories, protein, not just fat. So coming to the treatment, our aim of the treatment are multifold. One is to decrease the protection of chyle. Okay, so you need to address the basic etiology first. If it is cirrhosis, you need to treat the cirrhosis. There is no point in giving the fat replacement or something like that. You need to address the situation. If it is surgical, you may have to address the surgical cause. So in case of a cirrhotic patient, you have to take the patient for liver transplantation as well as possible, because cirrhosis with chylous ascites, 1 year mortality risk is 70%. You may lose the patient. Most often you end up in losing the patient unless you transplant the patient immediately. Then of course you need to replenish the fluid and electrolyte loss. Then prevent the malnutrition by repletion of nutrient source like fat soluble vitamin, and you need to address the underlying cause as I said earlier. So treatment options depend upon the severity of the leak. Sometimes you will be seeing only 100 to 200 ml, or as I told earlier, it may not be even a milky fluid, it will be just a turbid fluid. In this situation, your role comes, you only have the role, we don't have the role actually. Only dietary modification, you need to just modify the diet. Okay, and then little bit more severe cases, you need to give some pharmacological measures. And the intervention radiology, all surgical options are the last resort. The diet modification, you need to give low fat diet or fat free diet depending upon the patient situation. You need to see the patient as a whole, how emaciated he is or she is. And you need to give only 10 to gram fat per day. And you need to see the food labels, how much amount of the fat is there in one servings. Okay, it should be less than 0.5 gram. And you need to address the fatty acid deficiency, because fatty acid deficiency causes impaired wound healing, and patient is prone for infection and thrombocytopenia, and prolonged fat loss can lead to skin manifestations like eczema. Then the diet modification, the most important diet, the fat you can include is medium chain fatty acid. Why? Because it is getting directly absorbed into the portal venous system. There is no need of chylomicron. So you are decreasing the load of the lymphatic vessels. So this hole, suppose it is because of this hole is made by doctor surgeon, iatrogenic injury. So in this case, if the lymphatic, we can reduce the chyle leak, then that hole will eventually heal. So that's our idea. So reduce the chyle production. So to reduce the chyle production, so reduce the amount of long chain triglyceride you give to the patient. So supplement the fat by medium chain triglyceride. That's the whole idea actually. And fatty acid can bypass the lymphatic system. And this MCT that directly binds to the albumin and getting absorbed very rapidly in the portal venous blood. So you should be ready with a diet chart in your hand. You should not wait for a patient to develop chyle leak. This is not a very common situation that you face in your clinic. So when you get a call, you should be ready with a diet chart. This is a very short chart. I can show you big chart if you want, the PDF or something like that. So you need to give this chart like what all diet you can take, what all diet you should avoid. Okay. So coming to our area, like mostly our patients consume rice. So you can give them white rice, okay, fat-free bread, and cornflakes. You should avoid these corn chips, pancakes, and toasted bread. Okay, and this is very important. You should advise them only skimmed milk. Okay, and you should avoid whole milk and cheese. And when it comes to the non-vegetarian patient, you should tell them to have only egg white, okay, not yellow egg yolk. And you should avoid, you can take some fish, not all fish, try to avoid oily fish like sardine. Then this is not the only, some patient will not settle with this. So roughly we can classify this chylous leak or chylous fistula as high output fistula or low output fistula. Okay. So if the amount is more than 1 liter, but if your patient is emaciated, this is not a cutoff by standard cutoff by any organization. So if your patient is emaciated, you can reduce this cutoff from 1 liter to even to 500 ml. So then you should take this, even 500 ml you should take as a high output fistula. Okay. In this patient, it's better to keep that patient nil per mouth and give total parenteral nutrition. This is we consider when there is a high output fistula that is not reducing with your other conservative management like diet modification, and sometimes some patients they will not tolerate this median chain triglyceride. It's not that tasty actually. They will complain, madam, I can't take this. This is very like odd taste. Okay, I want to eat, especially milk and all. They will not be able to avoid. So in that case, you may have to go for enteral nutrition. You have to put a Ryle's tube. Okay. Then if still your patient is leaking chyle, the next option is octreotide. This is a long-acting synthetic analog of somatostatin. It's a natural hormone. So, and this reduces lymph flow as well as fat absorption. The typical dose is 50 to 100 microgram 3 times daily, and it has got some side effect like bradycardia. Patient will develop bradycardia. Staff, nursing staff may complain that after starting this medication, this thing, the patient developing bradycardia, and some patient may develop allergic reaction or even diarrhea. So this is a last resort, surgical option or intervention radiology. Previously we used to take these patients into the operation theater. Nowadays it is very rare. Actually we take if needed, most patients settle with the dietary or conservative management, and some patient if it is required, we go for intervention radiology option. Okay. This usually if there is a high output fistula like more than 1 liter after 2 or 3 weeks of the medical, pharmacological and dietary management, or the patient develop metabolic or severe nutritional complications. What we do in the intervention radiology, I'll go back to the previous picture. Sorry. Slideshow. What we do, this is here comes a cisterna chyle. So if there is a chyle leak somewhere over here, that happens in the pancreatic surgery after Whipple operation or after liver transplant surgery, then what they do is that they inject some embolic material like lipidol somewhere in the toe or in the inguinal lymph node. Okay. Then they will take serial X-rays or CT scan. They can see chyle leaking somewhere over here. Then they will inject some more lipidol or other embolic agents that will go and block the hole here. Okay, that's it. Sometimes it may be in the thoracic duct. So they can directly inject from the via ultrasound guidance or CT guidance. They can inject somewhere over here cisterna chyle, and they can block the hole. If it is somewhere leak is over here, especially in the neck dissection or the esophageal surgery, then they can inject the embolic material here. They can demonstrate the leak, and they can patch the hole here. Or we had to go, and if that is also not possible, we have to go and ligate the area of the leak. Thank you.
Thank you, Dr. Fadl, for that insightful session. We are now open for a short discussion. If anyone has questions or thoughts to share, please feel free to raise your hands. Any questions to the speaker? Okay, there are some questions on the online platform. Somebody has asked, is it okay to use coconut oil instead of MCT?
Coconut oil, though it contains MCT, but it's in the most dietary chart. If you go and see the most dietary chart, they don't usually recommend coconut oil for the Chyle Leak Management. But if no other option is available, you can use.
Okay, right, noted. Thank you so much,
If
sir.
you go and see the UK based diet protocol, they put the coconut oil in the coconut in the to avoid session. Okay. That's also surprising for me because in my earlier days we used to use this coconut oil. Yeah, MBOs. We have better options nowadays.
So my question is, once we know that we are managing the patient with Chyle Leak Management, how long does it take for the patient to recover in terms of start off with a normal way of eating, or does it need to be monitored now and then, or a follow-up needs to be given and all those decide?
Very good question. Actually, like you may become impatient actually. Some patient it will take 3 months. In one of our patients only after the transplant took around 2 to 3 months to settle. The patient will not tolerate this. I told them this is not that tasty food actually. They will not tolerate it. So your idea should be, the goal should be to reduce the leak. Okay. Then as it reduce, you can gradually introduce the food items which is like that not rich in long chain triglyceride. Slowly introduce that, and this is not only nutritional aspect also. These patients are prone for infection, leaking infection. They are losing lymphocyte. Okay. In liver transplant patient, we are already putting the patient on immunosuppression to prevent rejection. Okay. So they are very much prone to get infection. So you need to educate them very well. You have to spend time with them. Your team, entire team should spend with them. I would say you need to walk with the medical team doctors for the rounds to manage such patient. You cannot individually go and meet this patient. They'll shout at you. Definitely they'll shout at you. So the idea is, if it is not getting reduced within 2 weeks, step up your management. Either parental nutrition or pharmacological, or even if you are in that stage, you have to consider interventional radiology or surgical management. If interventional radiology is not available in your hospital, you can consider surgical management. It's not a failure actually.
Any other queries? Online, I think nothing else is there. Right. Thank you so much, Doctor. Your session really gave us a lot of practical insights into Chyle Leak Management. I call upon Ms. Sindhu as President Aedan to present a small token of appreciation to Dr. Fadl. Next, it is our pleasure to recognize the newly recognized dietitians who have joined our profession. For this, I would like to call upon Ms. Swapna I, L&D Coordinator, A.E.D.A.N, and Chief Dietitian, Renai Medicity, Ernakulam, to facilitate the new RDs.
Good afternoon all. Right nutrition is always the right of a client, irrespective of health, his health or sick. So a dietitian should be responsible for giving evidence-based practices. There comes the importance of credentialing of dietetic practices. This year, A.E.D.A.N has 2 members who have cleared RD examination in 2024. First, I call Ms. Rinda Roy, dietitian, Aster City, Rinda. She not only passed the RD exam but has also secured the 3rd rank. Kudos to you, Rinda. We truly appreciate your hard work and dedication. I would like to welcome Ms. Sindhu, President A.E.D.A.N, to hand over the memento to Rinda. I would request Rinda to give us a few words of encouragement.
Good afternoon. Actually, 2015 ഞാൻ പാസ് ഔട്ട് ആയതാണ്. അപ്പം ഇത്രയും നാളത്തെ എക്സ്പീരിയൻസിനുള്ളിൽ RD എക്സാം എടുക്കുക എന്നുള്ളത് ഭയങ്കര എൻ്റെ ഒരു എയിമായിരുന്നു. പക്ഷേ പേപ്പർ 1 പേപ്പർ 2 രണ്ട് ഇതുണ്ട്. അപ്പോൾ പേപ്പർ 1 എന്ന് പറയുമ്പോൾ ഫിസിയോളജി, അനാട്ടമി, ബയോകെമിസ്ട്രി, കുറേ സൈക്കിൾസ് ഇതൊക്കെ മറന്നിട്ടുണ്ട്. അപ്പോൾ അത് ഇപ്പം ഈ പഠിച്ചെടുക്കുന്നവർക്ക് എളുപ്പമാണ്, പെട്ടെന്ന് ക്ലിയർ ചെയ്യാൻ എളുപ്പമായിരിക്കും. പക്ഷെ ഇത്രയും നാളത്തെ ഒരു ലോങ് ഗ്യാപ്പിന് ശേഷം നമുക്കൊരു ക്ലിയർ ചെയ്യാൻ കുറച്ചൊരു ബുദ്ധിമുട്ടുണ്ടായിരിക്കും. പക്ഷേ പേപ്പർ 2 എന്ന് പറയുമ്പോഴേക്കും കുറച്ചും കൂടെ നമ്മൾ ഈ പ്രാക്ടിക്കൽ എക്സ്പീരിയൻസ് ഒക്കെ ഉള്ളതുകൊണ്ട് നമുക്ക് കുറച്ചും കൂടെ ഈസി ആയിട്ട് എഴുതാനും മാർക്ക് സ്കോർ ചെയ്യാനൊക്കെ പറ്റും. പക്ഷേ പേപ്പർ 1 എനിക്ക് കുറച്ച് ടഫായിരുന്നു. അപ്പം ഞങ്ങളുടെ ഡിപ്പാർട്ട്മെൻറ്റിലെ രഹര ചേച്ചിയൊക്കെ പറയുമായിരുന്നു, പ്രീവിയസ് ക്വസ്റ്റ്യൻ പേപ്പേഴ്സൊക്കെ നോക്ക്, റെഫർ ചെയ്യുക. അപ്പോൾ നമുക്ക് കുറേ കിട്ടും, എന്തൊക്കെയാണ് ഒരു ഐഡിയ, പാറ്റേൺസുകളും അതൊക്കെ കിട്ടും. അതനുസരിച്ച് നമ്മൾ കൂടുതൽ റെഫർ ചെയ്ത് പഠിക്കാൻ പറയും. അപ്പോൾ അങ്ങനെ ഞാൻ കുറച്ച് റെഫർ ചെയ്ത് കുറച്ച് നോട്ട്സൊക്കെ ഉണ്ടാക്കി അങ്ങനെയാണ് പേപ്പർ 1 ഞാൻ കുറച്ച് പഠിച്ചത്. കുറേ സൈക്കിൾസും നമുക്ക് വരുന്ന കുറേ സൈക്കിൾസൊക്കെ അറിയാലോ. അപ്പം നമ്മുടെ കോറി സൈക്കിളും അങ്ങനത്തെ സൈക്കിൾസ് എല്ലാം പഠിച്ചത് അങ്ങനെയാണ്. അപ്പോൾ പേപ്പർ 2 എന്ന് പറയുമ്പോഴേക്കും നമുക്ക് പ്രാക്ടിക്കൽ എക്സ്പീരിയൻസ് ആണ്, കേസ് സ്റ്റഡീസ് ഉണ്ടാകും, അബ്രിവേഷൻസ്, അതുപോലെ തന്നെ നമുക്ക് ഈ കുറേ കേസ് സ്റ്റഡീസ് ആണെങ്കിലും കുറേ സ്കോർ ചെയ്യാൻ പറ്റുന്നത് നമുക്ക് കേസ് സ്റ്റഡീസിലാണ്. അപ്പം നമ്മൾ ചെയ്യുന്നത്, ഞാനിപ്പോൾ ആസ്ട്രോമെഡിസിറ്റിയിൽ വർക്ക് ചെയ്യുമ്പം ഞാൻ ഇവിടെ ചെയ്യുന്നത് വെച്ചാൽ കൂടുതലും കേസസ് വായിക്കുമ്പം അന്നേരം തന്നെ എന്തെങ്കിലും നമുക്ക് കിട്ടുന്ന പോയിന്റുകൾ, ഇപ്പം അബ്രിവേഷൻസ് ആണെങ്കിലും അന്നേരം തന്നെ അറിയാൻ പാടില്ലാത്ത നോട്ട് ചെയ്ത് ഞാൻ പഠിക്കുമായിരുന്നു. അതുപോലെ തന്നെ ഇപ്പം പുതിയ കേസസ് ആണെങ്കിലും അത് വായിക്കാൻ ശ്രമിക്കും. അപ്പം വായിക്കുമ്പോൾ നമുക്ക് കുറേ കാര്യങ്ങൾ പഠിക്കും. നമ്മൾ എന്നും ഇത്ര വർഷത്തെ എക്സ്പീരിയൻസ് ഉണ്ടല്ലോ എന്ന് പറഞ്ഞുകൊണ്ട് നമ്മൾ പഠിക്കാതിരിക്കരുത്. അപ്പോൾ പുതിയ കാര്യങ്ങൾ നമുക്ക് ഓരോ കേസസിലൂടെ പുതിയ ഐഡിയാസും പുതിയ ഡയറ്റുകൾ എങ്ങനെയാണ് നമുക്ക് മോഡിഫിക്കേഷൻസ് എന്തൊക്കെ കൊടുക്കാം, എന്തൊരു ഗൈഡ് ലൈൻസ്, ഇതെല്ലാം നമുക്ക് അന്നേരം കിട്ടുന്നത് അതിലൂടെയാണ്. അപ്പോൾ അതൊക്കെ നമ്മൾ റെഫർ ചെയ്യുന്നു. പിന്നെ ഞങ്ങൾക്ക് ആസ്ട്രോമെഡിസിറ്റി തന്നെ എല്ലാ വെനസ്ഡേയും മാൻഡേറ്ററി ട്രെയിനിങ് പ്രോഗ്രാംസ് ഉണ്ട്. അപ്പം അന്നേരം നമുക്ക് കുറേ ക്ലാസ്സസ് നമുക്ക് കിട്ടും. അന്നേരം സുസ് മാമൊക്കെ ഞങ്ങൾക്ക് പറഞ്ഞു തരുന്നത് ഹൈപ്പോഗ്ലൈസീമിയയുടെ മാനേജ്മെൻറ്റൊക്കെ. അപ്പോൾ റീഫീഡിങ് സിൻഡ്രോം, ഡംപിങ് സിൻഡ്രോം, ഇതൊക്കെ ഞങ്ങൾ പഠിച്ചത് ആ ട്രെയിനിങ് സെക്ഷനിലൂടെ. അപ്പം നമുക്ക് ഇരുന്ന് പഠിക്കാനുള്ള എനിക്ക് ടൈം കിട്ടത്തില്ല. കാരണം വീട്ടിൽ ചെന്നിട്ടുണ്ടെങ്കിൽ കുട്ടികൾ, ഫാമിലി അപ്പം ടൈം സ്പെൻഡ് ചെയ്യാൻ പറ്റത്തില്ല. അപ്പം ഹോസ്പിറ്റലിൽ തന്നെ ഇരുന്ന് നമ്മൾ മാക്സിമം ടൈം കണ്ടെത്തി അത് പഠിക്കാൻ ശ്രമിക്കുക. അതൊക്കെയാണ് എൻ്റെ ടിപ്സ് എന്നൊക്കെ പറയുന്നത്. പിന്നെ പ്രീവിയസ് ക്വസ്റ്റ്യൻ പേപ്പേഴ്സ് നിങ്ങൾ റെഫർ ചെയ്യുക, നോട്ട് ചെയ്ത് വെക്കുക. പിന്നെ നമുക്കൊരു ബേസ് ഉണ്ടെങ്കിൽ നമുക്ക് മാക്സിമം എഴുതാൻ പറ്റും. അതാണ് എനിക്ക് പറയാനുള്ളത്. പിന്നെ എല്ലാവരും സപ്പോർട്ട് ചെയ്തു, ഫാമിലി ആണെങ്കിലും എല്ലാവരും സപ്പോർട്ട് ചെയ്തു. താങ്ക് യു സോ മച്ച്.
Thank you, Rinda, for your brief explanation. And now I would like to welcome Ms. Reshma. She's a dietitian, MGM Muthoot Hospital, Pathanamthitta. I would like to Ms. Sindhu to hand over the momentum. Reshma, you can also explain your experiences and guidelines.
First of all, thank you for this opportunity. ഞാൻ 2017 പാസ് ഔട്ട് ബാച്ചാണ്. പക്ഷേ ആക്ച്വലി എനിക്ക് ഒരുപാട് ഗ്യാപ്പ് വന്നിട്ടുണ്ട് ഇതിനിടയ്ക്ക്. മാരേജ്, കുട്ടികൾ, അതുപോലെയുള്ള കുറച്ച് കാര്യങ്ങളൊക്കെ കൊണ്ട് കുറച്ച് ഗ്യാപ്പ് വന്നിട്ടുണ്ട്. പിന്നെ ഞാനും ഇത് 3rd ടൈമാണ് ഈ ഒരു എക്സാം ക്ലിയർ ചെയ്യുന്നത്. അതായത് ഫസ്റ്റ് 2 പ്രാവശ്യം അറ്റംപ്റ്റ് ചെയ്തെങ്കിലും എനിക്ക് ക്ലിയർ ആയില്ല. ഫസ്റ്റ് ടൈം 2 പേപ്പറിനും കിട്ടിയില്ല. സെക്കൻഡ് ടൈം മീൻസ് തിയറി പാർട്ട് ഓക്കെയാണ്, പക്ഷേ പ്രാക്ടിക്കൽ ഓക്കെ അല്ല. പക്ഷേ ഈ ടൈം കുറച്ചും കൂടെ വേണം എന്ന് വെച്ച് തന്നെ കഷ്ടപ്പെട്ട് പഠിച്ചു, അതുകൊണ്ട് കിട്ടി. അതുകൊണ്ട് ഇനി സ്റ്റുഡൻസ് ആയിട്ടുള്ളവർ ഇവിടെ ഉണ്ടെങ്കിൽ അവരും കൂടെ ഒന്ന് കേൾക്കാൻ വേണ്ടി പറയാണ്. നമുക്ക് വേണം എന്ന് വെച്ചാൽ എന്തൊക്കെ പ്രശ്നങ്ങളുണ്ടെങ്കിലും നമുക്ക് മുന്നോട്ട് വരാൻ പറ്റും. പക്ഷെ വേണമെന്ന് വയ്ക്കുക, പഠിക്കുക, വായിക്കാവുന്നത് വായിക്കുക. ഇപ്പോൾ വിഷ്വൽ മീഡിയാസ് ആണെങ്കിലും എന്താണെങ്കിലും എവിടെ കൂടെ അറിവ് കിട്ടാമോ ആ ഒരു ഓപ്പർച്യൂണിറ്റി എല്ലാം തന്നെ യൂട്ടിലൈസ് ചെയ്യുക. ദാറ്റ്സ് ഓൾ. താങ്ക് യു.
Once again, congratulations on your achievement. Thank you so much.
Thank you. Moving ahead, it's time for the second scientific session of the day, Medical Nutrition Therapy in Chyle Leak. I am delighted to invite Dr. Manju P. George, Secretary of Aedan and Chief Dietitian, VPS Lakeshore Hospital, to share her expertise.
Thank you, Fisa. Very good afternoon, all present here. Thank you, Doctor, for the brief introductory session and medical management regarding the Chyle Leak management. So here, as dietitians, we all would have come across this once. I think how many of you have managed Chyle Leak in hospitals? Okay, few of you have managed. And for few, it may be a new thing also. We have heard of it, but directly we wouldn't have met the patient on how to manage. Theoretical part we may be knowing, but getting a patient and managing him or her is really tough job, as doctor said. And we have those who are managing them in the hospitals will be witnessing it on and off. Now, as we discussed Chyle, I don't want to give again a brief introduction on what is Chyle and what it is. The milky fluid, as we come across, usually in our hospital, after any transplant, we closely observe the drain tube and bag. So if there is any discoloration, we'll start preparing ourselves to be prepared with any of the outcome like that. And not only in the liver transplant, but in renal transplant also it was there. And other chylothorax also it was seen. It will be more or less like this when the bag, as doctor said, the milky white appearance. So the indications, the consultant and the medical team will be noting it down, and the triglyceride part they will be assessing from this, and depending on the variation we will get to know is it on an increase, and if there is any traces of triglyceride we will have to make the patient mentally ready first, and then the family also. Otherwise they will think that after transplant it's supposed to be completely okay, but now again so much of restrictions, so that will be a mental agony to them also. So that is very much needed. So communication is very much needed. So as Dr. rightly said, it's an alkaline fluid, and 1 liter leaves around 30 gram of protein and more of fat also. So we can imagine how much is the protein leakage happening and how much it makes the patient malnourished. So depending on when the nutrition guidelines are concerned, it focuses on restriction of dietary long chain triglycerides while correcting the nutrient deficiency. So we just need to not only need to control the excess fat, but also there will be definitely deficiency, and that will need to be addressed and corrected. So decrease the production of Chyle fluid is the first and foremost part of dietary management. Replace fluid electrolytes, maintain or replete nutritional status, and prevent malnutrition. So these are the ultimate goals. And as we know, it's really challenging to start a fat-free or low-fat or MCT-based diet. We can suggest the patient to start eating sip by sip or eat slowly. If it is a liquid, they can sip by sip the MCT oil, we all know, and now there are powders also arriving. So whatever the salts, it has to be slowly consumed. Start with small volume. We can call it as small shots also. Flavorings as needed, it can be added. Add to a fat-free beverage of choice. It can be juice or it can be black tea or whatever the patient likes. Consider diluting with equal volume of water. If they cannot have the oil as such, there are people who can just drink the oil as such. So for them it's okay. But otherwise they need to mix it with the liquids, or if they are having rice, they can have it with the rice and consume. Any curries they can consume. Without oil we can prepare it, and that also is possible. So any medium can be used, any fat-free medium can be used. With that, this oil can be incorporated so that the patient consumes it without hesitation. The goals of therapy are again as decrease the production of Chyle fluid, reduce, and the previous ones were listed. If there is an external drain is more, what we can do is, as we had listened to Dr. Fadl, NPO for few hours or 24 hours or more if required. Then start with TPN. So when the patient is on starvation, it will automatically come down because no dietary fat is going in. So we have faced so much of challenge, and in the last one of the patients, we are trying complete fat free, and doctor was telling this is not getting managed and how we can do it, because whatever dietary measures we are doing, still the patient was pouring and pouring lots of chyle. So we were also stuck in some way. But then we kept for some procedures, he was kept for NPO for some time, and then it was reduced. Once he starts, even in fat-free diet, the chyle was coming out. So that was very difficult situation, but we could, multidisciplinary approach was definitely helpful, and we could come out of the situation. Based on the result, depending on the route of administration, we can decide what kind of route is required. So MCT, we all know that's only one solution to diet-wise, it's MCT only. So MCT, when we check, it is thought to be absorbed directly to the portal circulation. That's why MCT is preferred to LCT sources. And this is a controversy, isn't it? What is this? Being a Keralite, we know what it is. Coconut oil, and it was, earlier days it was working, but now it is not working. Why? Because as we, in the previous session we rightly discussed, we don't know the purity of the packet ones. So in one session I heard one doctor was telling they lost hope in trying out all the oils and this thing, and the patient went back to his hometown, Trivandrum. He went to the temple, and they got that prasadam, some oil they gave, and he drank that, his chyle was vanished. So for him it was a miracle. So doctor was telling it could be because they served the pure coconut oil. So that would have served the purpose with the rest of the dietary management. That is also possible. So coconut oil is not only having MCT, it is having other long chain triglycerides also. So it could be one of the reasons that it is it cannot be completely utilized, but for certain population, when we provide dishes with limited amount of coconut oil, it was working. But those who cannot be controlled with the lesser oil, with the coconut oil, we need to stop that, and MCT only has to be started. Then, so that is about the coconut oil concept. Fat-free diet. In our hospital, we are using low fat initially with coconut oil or MCT, coconut oil base, but then of late we could see that it was still not doing to the 100% accuracy. So we had to stop any oil source, and then a complete fat-free diet was started. Then it was working with MCT oil as additionally provided. So when we say it is fat-free, it should be less than 0.5 gram fat per serving. And as in doctor's slides also we saw, it should be less than 20 gram. When we say it is low fat, it should be less than 20 gram per day, and per serve, it should be less than 3 gram of fat. So we are not providing any oily sources directly, but we cannot avoid pulses and other cereal grains, everything. It will have traces of fat. So we cannot reduce that, and so altogether it shouldn't cross more than 20 grams per day. The low fat has to be maintained, and this is noted in this reference. So fat-free methods can be taken. MCT, it is EFA deficiency also may happen. So this essential fatty acid needs to be introduced as a few 1 to 2 teaspoons initially. Once the excess chyle leakage is getting settled, so that deficiency can be addressed, or medically we need to check whether medically it is being addressed. So in that case we can have a multidisciplinary approach. Otherwise, after discussing with the consultant and the medical team, it needs to be started. Supplements to be fat free. Now we have currently peptide based thing, but why we use peptide based is because of the MCT oil. MCT, 70% MCT it is having. Now we have other formulations also, intact proteins with more of MCT base. So choice of formula also can be used as per. So the summary should be adequate protein needs to be maintained. The toughest part is when we add non-vegetarian foods, chicken or fish without oil also we can cook and give, but still it has certain fat in it. So that fat also may cause the production of chylous chyle induction. So that needs to be addressed properly. So the protein source from other sources needs to be supplemented. Egg whites are really a boon to the system. So those who cannot consume egg whites, we try to convince in somehow, otherwise it's really very tough. So most of them consume egg whites, otherwise they'll have to have more of pulses. There is no other go. We can't give paneer and things like that. So that becomes a tough job to the dietitian, but depends on the patient's adherence to the diet also. So that overall convincing needs to be done, their satisfaction needs to be checked, all those parameters play a major role. So EFA we discussed, and fat soluble vitamins also as per the requirement in consultation with the medical team it's to be provided, because in the IV solutions and intravenous formula it will be added mostly. So we cannot blindly give those things. So that's why the multidisciplinary approach needs to be there. Few choices are there, vegetables and fruits, these can be consumed. Few are the abroad choices, but we can select whatever is applicable in our system for the betterment of our patients. The flavor and texture modification can be done. Mostly there will be diabetics or steroid induced diabetes will be there. So at that time we cannot give jam, jelly and those things. So the replacement of that needs to be found out. So likewise, these are the fruits and or vegetables which needs to be avoided. The fat containing ones, canned in oil, those vegetables. Coconut as such we are not providing because it is having a good fat, but the MCT oil part is fine with that. Breads and those things, whole milk. So all these things are having more or less small or higher amounts of fat. So that needs to be addressed and to be avoided from the patient's diet. While coming to meat and meat alternatives, white fish is suggested. So even compared to the other kinds of fishes, it's better, but need to see whether chyle leak is increasing with the consumption because of the natural content of fat in these items. So these are few options for the meat alternatives. Fats and oils, we have not used these alternatives in our system, but the references say these are the best choices among this group. And these are to be avoided because it has the invisible fat in it, so needs to be avoided. Whole eggs, egg yolks, so as you all know, these are contained with the fat only, so these options needs to be avoided. Now this is with egg white, so this is taken in our system. We haven't given, I think, any of you have given such items? No, we don't get into much because this is abroad, it's maybe used. So these are the options are given. So if somebody can suggest a person to do such things at home, they'll be baking cakes and those things, so they may know how to do these things. So the preparation method with these fat-free options can be done. So these are the choices what can be given to the patient for a better choice. Otherwise the options are limited in the day-to-day items. Soups, we suggest them to have soups, but sometimes it is mixed with creams and other oil sources. That needs to be careful. Even the more curry of curd, everybody lives on curd after transplant or something, but that is also getting restricted because of the fat in milk. So, and the pulsheri, more curry also, at least some taste they will have, but that is also restricted. So what will they have? That's a tough question. So some other alternatives needs to be found out so that the patient is also mentally satisfied. All these comes with the proper patient education. Unless and until the patient is convinced why this restriction is there, it is for their improvement only. And family also needs to be educated. Otherwise, they leave the dietitian's head. They will be very nice doctor when they go for rounds. But when we go, all the complaints and all the frustrations will fall on the dietitian's head. So that it has to go hand in hand. So we should be convinced first, and then we will be able to convey the message to the patient. So healthcare professionals, it should be a team approach. As in all the CNUs we are mentioning, the team approach is very much essential. Case studies are needed more. We have included 2 case studies from 2 different hospitals. So this only will support for the practical side how we can manage these kind of cases. So this is a good protein has to be there, low fat, proper hydration needs to be maintained, and overall improvement supports in that. These are few references for this. And thank you for the patient listening. Thank you from Team A.E.D.A.N and Team Lakeshore. Thank you once again.
Thank you, Manju ma'am, for your comprehensive and enlightening presentation on the nutrition therapy approach to managing Chyle leaks. The floor is open for questions. Anybody has any queries, please do come forward.
We avoid buttermilk because some traces of fat will be there. So those who are pouring Chyle, it may contraindicate. So once it is reduced and it is less than 50, so then it is okay. The triglyceride level is coming down, slowly we introduce. Otherwise we have tried buttermilk also, but it was not reducing. So for the safer side, we avoided that.
When we are on a fat-free diet with MCT oil for Chyle leak, how much MCT oil should we actually give?
Yeah, there is no proper guidelines on how much to be given, but as per the normal fat, how much is 30% is a normal fat suggestion. So with that we can give. So more or less it will come to 30 to 50 ml per day. So we have started with 5 ml 3 times a day. If tolerated, 10 ml 3 times. Then maximum 45 ml to 50 ml is provided. More than that also may induce some MCT may escape the lymphatic system, and if it is excess may cause the load.
Okay. So the Chyle may leak more. Is it like the volume may increase?
It may happen if the volume is high. So it should be like 30% of total calorie intake from fat. On that basis we can plan it.
Okay, ma'am. Thank you.
Any other queries? Online nobody has asked anything. Okay, thank you so much, ma'am.
Thank you for patient listening.
I now invite Ms. L.V. Sebastian, Treasurer A.E.D.A.N and Senior Dietitian VPS Lakeshore Hospital, Kochi, to highlight A.E.D.A.N's activities since August 2024. Since doctor is leaving, we will take a group picture. Thank you so much. Thank you so much, doctor. I now invite LB to please highlight A.E.D.A.N's activities since August 2024 and to announce this year's awards. LB, please.
Good afternoon all. I am here to give a quick review on various activities conducted over the past months. A.E.D.A.N is a premier organization dedicated to advancing nutrition science and supporting the best practices in the dietetics department. On 25th August 2024, A.E.D.A.N took a significant step in installation of the new office bearers. And on that day, A.E.D.A.N successfully conducted a state-level CNE event on advances and challenges in ongoing nutrition by Mr. Shivshankar Timempati, and which was followed by a panel discussion with esteemed faculty members. As we know, the RD results were published this year. I would like to congratulate Ms. Rinda Roy on securing the 3rd rank and Ms. Reshma VK on clearing RD examination. Congratulations both of you. And on September 2024, we started the membership drive on various categories. And as a part of Nutrition Month, Poshma 2024, various activities were conducted by the members from September 1st to September 30th. On 3rd September, we announced the article writing competition winners. And the first, and I would like to invite Ms. Sindhu S for the first and second prize distribution. The first prize was secured by Ms. Lashmi S, KVN Super Speciality Hospital, Cherthala. Second prize, Ms. Akshaya G, VPS Lakeshore Hospital. She's sending the doctor to send the doctor. And third prize was secured by Ms. Rakima C, Aster Medicity. On 7th September, an online webinar was conducted on topic Resolving Diabetes in association with Tincham Organis. And as a part of Onam celebration, A.E.D.A.N Onam celebration, a poster was created wishing every A.E.D.A.N members on a joyful occasion of A.E.D.A.N social media committee. On the 7th September, that a program conducted by Ms. Amida Jacob and team in association with A.E.D.A.N at KCYM Nelambur Mekala, and we conducted a 2 successful case presentation on 19th September and 17th October, coordinated by A.E.D. committee, Ms. Rehana Rajan as an in charge and Ms. Maureen and Ms. Swapna as coordinators. And we are looking forward, we are excited to announce that from coming months, our case presentation will have a new twist. We will be introducing a friendly competition format to make the section more enjoyable. We started our annual subscription drive on 17th September onwards, and now we extended for the next 2 weeks. A.E.D.A.N newsletter was published, the last newsletter on September, and there was a program conducted on 6th October on awareness section and fitness workshop at Little Flower Church, Trikakara, with a total of 100 participants. And these are the activities which were done by our A.E.D.Ns. There are 23 reported activities, and from which the first best performer of the nutrition month is Ms. Rashmi S. She done 4 activities, and Ms. Fisa Nawaz 3. Please give a big round of applause to both of them. Last but not least, I would like to invite our former president, Ms. Dr. Mumtaz Ismail, to the stage to announce a wonderful achievement.
It's a great happy moment for me to announce this award. I think it's a surprise to her, but it's appreciation to all of you. So we are announcing, the A.E.D.A.N is proudly announcing to congratulate Ms. Sindhu S. for the abstract entitled Risk Screening Tool for Pregnant Women to Prevent Gestational Diabetes Mellitus for being the top 10 winning abstract at the oral presentation, the Apollo International Clinical Nutrition Update held at on 28 to 29 September at Udaipur. So congratulations Sindhu for this achievement.
Thank you so much, ma'am. Thank you so much, Mumtaz ma'am. Thank you so much, Ms. LB, for keeping us updated on A.E.D.A.N's achievements and initiatives. Next, we have the case presentations. First, we welcome Ms. Dishya Dev from VPS Lakeshore Hospital to present her case.
Hello, good evening everyone. So I am here to present a case study on the topic post-liver transplant with Chyle leak. Not going into much introduction because we have already familiar with chylous ascites and all. So its content and its risks are mentioned here. Getting into the patient profile. So the patient is a 54-year-old male candidate who is a religious teacher, and he got admitted on 19th of June this year in the hospital, and the length of hospital stay was around 79 days. The anthropometric measurements: height 168 centimeter, the measured weight or the actual weight when he got admitted to the hospital was around 56 kilograms, and because he got moderate ascites, his dry weight was calculated using the formula by subtracting 10% from the measured weight, and it was found to be 50.4 kilograms. His BMI, according to WHO classification, was found to be in the underweight category, and the ideal body weight was calculated using Lemon's formula, and it was found to be around 62 kilograms. The nutritional assessment was done using SGA tool, and the score was given B because he got a severe weight loss before he got admitted to a hospital, and muscle wasting was also observed, and because of the inadequate nutrition too, he was scored B. No food allergies or intolerances were found. So the biochemical parameters, the LFT was quite little fluctuating in the initial stages, but it got stable during the time of discharge. The creatinine levels were quite little fluctuating in the initial stages because he was diagnosed with hepatorenal syndrome too. So it also got settled normal during the time of discharge. The medication and treatment. So he was on immunosuppressant. Cap-Pangraph was the immunosuppressant used. So it was found to have a drug-nutrient interaction with grapefruit. And tab-ecosprin was found to have a drug-nutrient reaction with the alcoholic beverages and grapefruit. No other drugs were found to have any other drug-nutrient interaction. So the clinical data, The presenting complaints like abdominal distension, breathlessness, fever, and upper GI bleed was also there. Currently, he was admitted for liver transplantation after all the liver transplant workup was done. So the past medical history, he was diagnosed with decompensated chronic liver disease with portal hypertension, type 2 diabetes mellitus for past 10 years, hypothyroidism, hepatorenal syndrome with acute kidney injury, surgery for renal stone in 2020. The medical diagnosis, decompensated chronic liver disease for living donor liver transplantation. So the 24-hour diet history, the energy was found to be 1560 kilocalories, carbohydrates was around 22 grams, 30 grams of protein, 55 grams of fat, and 28 grams of fiber. The food preference after coming to the hospital, it became non-veg, but before he was lacto-veg. Food intake was moderate. So the nutritional diagnosis, best statement, inadequate intake of protein from non-vegetarian sources related to religious beliefs as evidenced by patient verbalization. Inadequate oral intake related to food nutrition related knowledge deficit as evidenced by diet history. Inadequate macronutrient intake related to physiological conditions as evidenced by severe weight loss, muscle wasting, and diet history. Coming into the main part, the nutritional intervention. So the recommended total energy expenditure for post-liver transplant was around 30 to 35 kilocalorie per kg body weight. The recommended carbohydrate, 50% of total calories, 20% of total calories from protein, 30% of total calories from fat, 20 to 35 grams of fiber. The reference is given below. So the medical nutrition therapy goals, the short-term and long-term goals are mentioned. So the short-term goals to maintain a reasonable weight to prevent weight loss, provide adequate protein to prevent muscle wasting, implement a fat-free diet along with medium-chain triglycerides. Long-term goals, maintain ideal body weight throughout the life, continue a diet that provides adequate macro and micronutrients to maintain overall health and prevent malnutrition. So the nutritional prescription was, energy was taken as 35 kilocalorie per kg body weight. It was around 1750 kilocalories per day. Carbohydrates, 240 grams, which is 55% of total calories. Because he was in the underweight category, we just increased the carbohydrate percentage in the diet. Protein, around 88 grams, which is of 20% of total calories. Fat was given around 48 grams, 25% of total calories, but it is like included with MCT oil, it was given 25% of total calories. Other than that, it was 20 grams below with the food alone. Fiber, 25 to 30 grams. So the pre-transplant nutrition was also assessed for the patient. So the ascitic fluid tapping was done for the patient, and in different days, his triglyceride levels were checked, and it was found to be decreasing with days, and the nutrient intake on those days are also mentioned here. So the protein intake, we can see it got increased later on after few days, and the triglyceride levels were also in the decreasing manner. The diet was kept before pre-transplant, it was kept diabetic, hepatic, fat-free, MCT-based diet because of high triglyceride levels in the chylous ascites. Oral nutritional supplement was used to improve the patient's overall health and to prevent further muscle wasting. Because he was lacto-veg when he came to the hospital, we recommended the oral nutritional supplement because he was only taking pulses and all. So oral nutritional supplement was included. MCT oil was used to meet the caloric requirements from fats. Diet progression during the hospital stay. So the date of surgery was on 20th of July 24. POD 1 and 2, he was nil per oral. POD3, diabetic clear liquids were started, followed by diabetic high protein liquid diet. With POD4 and 5, diabetic high protein soft diet was initiated. With little drain color was little visible, like it was like a milky drain fluid in the 4th, 6th and 7th POD. So it was changed to diabetic high protein low fat diet, but it got increased after the days. So by POD8, diabetic high protein fat free MCT based was initiated. So by day 8, POD8, POD25, POD34, POD44, the nutrient intake was getting increased and improved. So he was started having egg whites. He was by the end of the day, like by the discharge day, he was having around 20 egg whites, I guess. So the average was also, the nutrient intake was also good by the end of discharge, by the time of discharge, sorry. So this was the prescribed diet. It consists of 1700 to 1800 kilocalorie, 85 to 90 grams of protein, diabetic high protein, fat free, MCT based diet was prescribed during the discharge too. It included pulses and egg whites as the major source of protein, and other carbohydrates were also include. Semile MCT oil was used as nutrient for fat. And the remarks, small frequent meal pattern suggested, protein dense options were discussed, advised regarding using MCT oil in the diet. So the comparison of hospital diet and prescribed diet with modified RDA. So we can see the prescribed diet percentage was quite in the normal range only. And the hospital diet, while comparing with the modified RDA, had a little larger differences. And he got really improved at the time of discharge during the hospital stay. So concluding, 54 years old male patient came with complaints of abdominal distension, breathlessness with moderate ascites, and was planned for liver transplantation. Initially, the patient's oral intake was assessed and found to be inadequate considering his nutritional requirements. Certain nutrient-dense options along with nutritional supplement was included to meet the caloric requirements. He was put on a diabetic fat-free MCT-based diet during pre-transplant because of chylous ascites found during ascitic fluid tapping, and triglycerides in ascitic fluid were found to be high. After few days of transplantation, he was put on a diabetic fat-free MCT-based diet because of milky drain. To meet his protein requirements, egg whites, pulses, etc. were included in the diet. As days passed, his nutrient intake got better. During discharge, he got discharged by POD 47. The patient was advised to continue diabetic fat-free, high-protein, MCT-based diet. The drain volume also got reduced at the time of discharge. The discharge weight was recorded and was found to be 56.4 kilograms. After few days, drain fluid gradually reduced and found to be nil. He was advised to continue the same diet for few weeks more. On 29th of October 2024, CT was done and no fluid collection was found. He was advised a diabetic high protein low fat diet for a week, and weight checked was around 63 kilograms. So we can see the weight gain within the period, like it was 56 at the time of discharge and he gained a good amount of weight by this month. These are the references. Thank you.
Thank you so much, Adrisha. Now let's move on to the second case presentation. It will be delivered by Ms. Ansi Vijay from Aster Medicity, Kochi.
Hi, good afternoon, one and all. So, I'm going to start my case presentation on Chyle Leak in liver transplant. So, I'm not explaining in detail about what the introduction part of Chyle Leak, but I would like to show that in general, when chylous leak is present, and there are certain symptoms that we can see in a patient, especially that can be categorized as mild or severe symptoms. In general, what we have normally seen is mild to moderate symptoms only, which comes only in mild abdominal distension, and at that time diet might also be tolerable. But whereas there is another condition where symptoms are severe. At that moment, the patient might feel anorexic or nauseated. Even dyspnea also will be seen. During that time, we as dietitians have to consider giving a low-fat diet or fat-free with MCT, as we have already studied. Even TPN has to be considered if any of these mentioned symptoms are if the patient isn't having any severe symptoms. Moving on to my patient, this patient was a 65-year-old businessman, and he got admitted on January 8th, and he stayed in the hospital for 24 days, and he was categorized he was actually to an obese side, and especially his weight was highlighted because the weight mentioned here is with ascites, so it was almost around 96.2 kg at that time, and his height was only 156, and the ideal body weight comes around 53 kg. Here we haven't calculated BMI because it was not applicable here, and we took the dry weight as 81.5 per kg, 81.5 kg approximately, and using SGS score he was moderately malnourished. So the reason for admission was for living donor liver transplant, and the medical diagnosis was DCLD with portal hypertension and child B MELD score 24, and he is diagnosed since 6 years, and he also had a past history of urinary tract infection which was resolved. He also has a past medical history of systemic hypertension since 3 years. And while clinically examining, he was paler, icterus, and had edema with ascites. Also was having pitting pedal edema in bilateral limbs. So these were the parameters post-surgically, and it is observed that our HB was slightly lower side because of the drains and all, but it was also corrected by giving RBC, and then sodium were not in the normal level, but it was in the manageable range only. Even potassium were also not beyond the range, and bilirubin was coming to the normal ranges at the time of discharge, and as usual, as we normally see, serum albumin was in the lower side, and he was not diabetic, and the SGPT, SGOT variations also were coming back to normal by the time of discharge. These were the medications, and the common drugs which had interaction were tacrocort, which is an immunosuppressant, and ecospirin, which was already mentioned earlier, and most of the other medications were not having any drug-nutrient interaction. Then this was the diet history by the time of the transplant. Even though the patient was stable, his intake was not that sufficient at that moment, but still he was managing to consume some good amount of protein with the help of non-veg and a protein supplement. However, the total quantity was not that sufficient. So the PES statement were limited food acceptance related to poor appetite and food aversion as evidenced by patient frustration and food refusal. Also altered nutrition related lab values related to liver dysfunction as evidenced by deranged lab values like serum albumin. These were the nutritional prescription. We considered giving 30 to 35 kilocalorie per kg ideal body weight because he was in the, even the dry weight was approximately in an obese category, and the protein considered was 1.5 gram per kg, and we took 55% of the total calorie as carbohydrate, and we considered giving 28% of total calorie from fat, and these guidelines were taken from A.E.D.A.N. The medical nutrition therapy goal were to improve and maintain optimum nutritional status and to reduce length of hospital stay and to reduce mortality and morbidity, to preserve lean muscle mass, fat restriction to decrease the production of chyle and replace fluid and electrolytes, also to aid in wound healing, to improve the quality of life and maintain ideal body weight throughout the life. Okay. So this was the diet during the hospital stay, especially after the surgery. So in the beginning, he was kept NPO post-surgically, and then he was started on clear liquids. We do consider giving him neutropenic clear liquids, and later on period 5, he started having semi-solid, because it took almost 5 days for him to give some solid because he hadn't passed stool. Then we waited till then to have some solids, and then he was gradually progressing, and then on POD 11 it was found that a normal turbidity in the drainage, there was a turbid color change, or not that milky, it was only a turbid change in the drain which came out, and it was not in a huge amount, it was very slowly starting, and thus we started, the moment we saw that, we changed the diet to fat-free diet, and we gave him MCT oil separately to be added with food in order to make it a MCT based meal. Then we have made him continue with the same diet for almost the coming days till POD 21, because POD 22, but somehow he was managing to consume the solids that we encouraged him to eat a lot of solid, because he somehow wanted to get out of the hospital soon as he was recovering. He was literally he wanted to move out and come back to his normal life, and he was trying himself in order to consume some good amount of solid. And we also gave him an oral nutritional supplement which was MCT based at that moment in order to maintain his calorie consumption. So these were the energy, protein and fat graphically. This was how he was improving. And the prescribed menu was this one, and we planned to give him 1890 calorie with 80 grams of protein at the time of discharge. So to conclude, we had a patient with DCLD which was diagnosed on 2018, and his USG showed CLD with dysplastic nodules in periportal region with borderline splenomegaly. Nutritionally he was assessed and he was categorized as obese, but he was started on clear liquids on POD 3 and gradually improved, and diet was progressed. POD 11 chyle leak was observed, and a sudden change in the diet was made with neutropenic fat-free high protein with MCT oil in the diet, which resulted in decreased food intake. As the chyle volume decreased, he improved orally as well. And at the time of discharge, the patient had normal GI functions, non-edematic, and his weight at the time of discharge was 83. And the diet prescribed was neutropenic high protein low fat diet with the help of oral nutritional supplement, and he was on a regular follow-up, and currently he was lately he was on 79 kg last time. So that's all about my case presentation.
Thank you for that insightful case, Ms. Ansi. I would now open the floor for suggestions, comments. I would request Ms. Dishya Dev to also join the dais. Anybody has any suggestions, comments, please come forward. I request anybody online as well to please come forward and give any suggestions or comments or queries, please come forward.
My doubt is regarding the diet plan that both of you have given. It looks entirely different in nature. One person has given more of an egg-based diet with egg whites over how many? 20. Yeah, and the other person has included chicken also in the menu. So my doubt is when you give about 20 egg whites in a day, did you check with the patient, or did the patient say anything about gastric problem wherein he is not able to consume so much, or was a progression in the number of egg whites that you have included? How did you step up the progression for everybody's benefit? If you can explain over how it can be incorporated in a regular diet, that's for you. And for Ansi, my question is the same thing. When we convince a patient about how to incorporate the MCT in the diet, how far do you think are they able to manage with the oil being added into the food, or in your case, was the patient able to consume it even otherwise in the diet?
Thank you, ma'am, for the question. So, the first, as I already mentioned, that the patient was lacto-veg, but when he came to the hospital, he started consuming eggs and all. So, first we introduced one egg white, and he was not tolerating it. So, we didn't force him and let him have the pulses and all in the pre-transplant stage. And after that, he started, like, he knew that he needs some proteins in his diet. So he started having, he tried to have egg whites again, and then we increased the numbers. Before transplant only, he was having around 5 egg whites. So he was okay with that. And after transplant, he was not ready to have the egg whites for the few days, in the initial days. After that, he understood that it is needed. We counseled him properly. So he understood, and after the Chyle leak was formed after transplant, we explained him regarding the protein leak and all. He understood that also, and he was ready to have egg whites, and the pulses options were also there. And after shifting from ICU to the room, he was started having about 10 egg whites per day, and gradually we increased that. So he was tolerating, no other gastric issues were found. Before transplant there was, but after transplant it was not found. No, he was having vegetables and all, having proper fluid and all. No constipation was found. He was tolerating. No other patients I know that they were having around 10 or 9 egg whites, but this patient was having around 20 egg whites at the time of discharge.
Okay, so in my case, the patient was actually having difficulty in consuming. The moment we changed from a normal fat, from a low fat to a fat-free diet, it was very difficult because of the taste of change in taste and all. Then he was not that happy at the beginning. He was only consuming kanji or some oats without taking any curries and all. But somehow his wife helped him by incorporating it with the protein drink that we were giving, also with the curries. We only told them to give only 15 ml per day, that is 5 ml per meal. So it was they were able to manage, but he was not that happy at all. But at the end, he was every day, the moment we entered the room, he used to ask, so how is today? Shall I try something else? Can I have something else? Then depending on the Chyle leak which was seen, we had to tell them that, no, not today, we have to wait for some more time. Please do focus on what you're consuming now, and try to take whatever is being suggested currently. And as he literally wanted to get this Chyle and all this situation to get resolved. And he himself tried to focus on whatever we served. It was not a huge amount that he was consuming, but he managed to take those 5 ml 3 times a day, but we didn't increase the volume of 15 ml in any other day. It was only fixed 15 ml throughout. We didn't add more than that till the discharge. But by the end, towards the end, actually it took only 4 or 5 days, but as the Chyle leak was progressing to 1000 and it came back to gradually vanished at the time of discharge. But he was discharged with the drain, but it was observed also in every 5 days, like through OP basis. He was watched on the drain part, and gradually it came down. Then ultimately at the time of discharge it was only low fat with MCT oil, and the oil which was suggested to used in the kitchen, and that too very minimal. We gave him an amount like not more than 15 ml again, that cooking oil. But somehow in the most important curry that he wanted to have, we suggested to add those coconut oil into it. And as a medicine, he had to consume that MCT oil again, because his requirement was almost 50 ml. We had to meet 50 ml. So it was like 15 we managed.
Very good presentations, both of you. I think everybody would have got an idea on how to manage it. And see, the neutropenic was given because it was a post-transplant.
Yes,
Any
we
other
generally
reason?
follow a neutropenic diet for all the post-transplant patients.
Okay. Curds was included?
Curds, we suggest them only the sealed ones,
Okay.
not the open.
So only for the
buttermilk or
safety
closed.
purpose, the neutropenic
Yes,
intimation
yes,
was given.
we do recommend that.
Thank you for the presentation. My question is to Ansi ma'am. In the prescribed diet, I have seen fruits were included in the diet. So the strictly neutropenic diet was advised till how many months you have?
No, actually it is till minimum 6 months to 1 year we do recommend.
Okay.
Fruits with thick skin we do recommend even at the time of, even if the patient is at the hospital, we do say yes. Because the handling and the only thing is we do not allow them to take directly from the kitchen.
Okay.
We recommend to buy a whole fruit from the kitchen and to cut and serve at the moment the patient requests for it.
Okay.
And the remaining part won't be served to the patient. We would suggest somebody else can take it. Don't give the leftover fruit which is remaining.
Okay. Thank you.
We do recommend fruit also, but only the thick skin ones.
So I think the queries, well done, very nice, both of you. Thank you so much.
Thank you.
Let's give a big hand. These cases have really deepened our understanding of practical challenges and solutions in Chyle Leak Management. Thank you so much. As we move on to the final stretch of today's program, I am honored to introduce our third scientific session. We will hear from Dr. Mumtaz Khalid Ismail, Founder President of A.E.D.A.N and Consultant Clinical Nutritionist, Total Nutrition Plus. She will present on dietary fiber. Over to you, ma'am.
Good evening. So my topic is slightly different from what you are listening so far. I'll be talking on the importance of fibers in managing gut health. We were listening more of fat so far, so I'll be talking more about fiber. So as you all know, the journey of fiber does not end when it reaches the colon. Rather, it undergoes a fascinating transformation which goes into the gut with trillions and millions of microbiomes residing in our gut. So the fermentation process of fiber by these gut bacteria is a cornerstone of the thriving and the diverse microbiomes. So the dietary fiber has gained a significant attention for its crucial role in digestive health and its broader impact on overall well-being. All these years we were mainly focusing on proteins, but recently the fiber has become a major hero. So it's only, you should understand the fiber is only partially digested, allowing some of it to reach the large intestine where it serves as the food source for the beneficial gut bacteria. This microbiomes undergoes rising in the gut health is essential not only for the digestion but for also for metabolic and immune and even for mental health. It is very important. So what is dietary fiber? You can see from the picture, in the historic age, people used to eat more of grains and vegetables. But recently, we are more into processed foods. We have reached that stage of eating more of processed foods. Dietary fiber, as you all know, is a type of carbohydrate that resists digestion and absorption in the small intestine. Unlike all the other carbohydrates that break down the sugars, the dietary fiber passes through the digestive system relatively intact, eventually reaching the large intestine, where it has the beneficial effects on the gut health, where the metabolic function and more happens in the gut. So resistant to digestion, if you, carbohydrates, if you look into it, unlike the simple carbohydrates, they are broken down by the enzymes in the small intestines. The dietary fiber travels largely unchanged to the large intestine. So the primary objective of understanding the dietary and the microbial interactions is to reveal how diet shapes the role in impacting the gut microbiome, and how it turns the microbiome affects the health outcomes. Fiber also acts as a key nutrient in relationship in influencing the composition and activity of gut bacteria, which produce short-chain fatty acids and other metabolites that benefits the host. Dietary fibers are normally found in cereals, as you all agree, cereals, fruits, vegetables and nuts, and plant-based non-digestible polysaccharides with two primary sources: soluble fiber, which dissolves easily in water, which forms viscous particles, in contrast to insoluble fiber, which does not dissolve in water and remain undigested without providing any calories. The consumption of dietary fiber offers several health benefits, as I am sure that all of you will agree, that it reduces the risk of CVD, it prevents excessive weight gain, regulates the rhythm of bowel movements, positive effect in the gut microbiome, promotion of both innate and adaptive immune responses, improves metabolic control of diabetes. So it plays a major role. The dietary fiber offers several additional benefits. When we dive deeper into this dietary fiber, other than these important categories emerge into the other categories like non-starch polysaccharides, resistant starches, and resistant non-digestible oligosaccharides. These fibers contribute significantly to the digestive health and have specific prebiotic benefits, supporting a balanced and diverse gut microbiome. Non-starch polysaccharides, they are found mainly in cellulose, hemicellulose, lignin and pectins. The primary sources are plant-based cells found in whole grains, vegetables, fruits and legumes. As we agree that they are largely insoluble, meaning they add bulk to the stool and help prevent constipation by increasing the fecal mass and promoting bowel regularity. They also help in slowing the carbohydrate absorption to regulate the blood sugar levels. As I said earlier, this fermented specific bacteria in the large intestine contributes to microbial diversity and balance. Resistant starches are mainly found in plant-based foods that contain starch resistant to digestive enzymes. Sources include mainly green unripe banana, cooked and cooled potatoes, legumes, whole grains, and certain types of rice. They largely pass undigested to the large intestine, where it is fermented by the gut bacteria. This fermentation process produces a beneficial short-chain fatty acids, such as many gut lining and anti-inflammatory effects are happening. This again, the insulin sensitivity aids in the blood sugar control and promotes satiety, which makes valuable for weight management. Resistant and non-digestible oligosaccharides, they are found in short-chain simple sugars that the small intestine cannot digest. The food sources can be onions, garlic, leeks, asparagus, bananas, and specific fibers like inulin and fructooligosaccharides. These are powerful prebiotic properties, especially nourishing beneficial bacteria like bifidobacteria and lactobacilli. When these are fermented, this supports gut health, reduces inflammation, and maintains a balanced microbiome. Now, many of the patients come to us and they diagnose themselves and come to us and say that I'm having inflammation, give me an inflammation diet, free diet. So, these things we have to understand before we prescribe the diet plans. They are also crucial in the gut environment by promoting immunity and potentially lowering the risk of certain diseases by fostering the beneficial bacteria on harmful strains. If you will look into the global fiber intake and recommendations, like average global index is 20 to 35 gram per day. Whereas if you look into the global scenario of Northern Europe or Australia, they have higher intakes due to the whole grains and the vegetables they consume. Recently I have traveled to Europe and I have found that the eating habits are totally different from what we are eating. They eat a lot of greens and vegetables and they don't even add salt to their food. Very less of spices and herbs they use, and so their fibers are very intact. The proteins are also of high quality protein they have. So coming into the dietary habits of our country, of body size and culinary traditions, you can always think about our dietary fiber intake, whether we are reaching the right requirement. The current intake, some studies says that we achieve 15 to 41. That also, are you sure that we are getting that? If you just look into a dietary recall of, if a person consumes morning breakfast as rava upma, lunch rice and fish curry and cabbage thoran, and dinner chapati and dal curry, how much fiber that person will get? Just think about it and see that our recommendation says that we have to take 40 grams per 2000 kilocalories. So are we achieving that for a normal individual? And when we talk into the therapeutic part, the scenario changes again. So are we achieving the target is my question to all of you. The role of fiber in gut health. Fiber plays a crucial role in the gut health by promoting beneficial bacterial growth, enhancing microbial diversity, producing short-chain fatty acids, supports growth, promotes regularity, enhances absorptions. All these things happens, and it also helps to improve all digestive function, contributing to the balanced and resilient microbiome. Fermentation by gut microbiome which is in nowadays because short-chain fatty acids are crucial metabolites produced through microbial fermentation of dietary fibers, and they resist starches in the large intestine. Their importance is now recognized in managing and preventing a range of health conditions from digestive disorders to metabolic diseases like diabetes and obesity. they benefit lot of metabolic health, gut barrier integrity and inflammation reduction, all is happening. And this fiber, if you, when we think about this microbial diversity, it's shaping and sustaining the gut's microbial communities, being a diversity and functional beneficial bacteria. When fiber-rich foods reach the large intestine, they serve as a primary fuel source for the gut microbiome. The fermentation of the gut fiber by these microbiomes produce beneficial metabolites, including short-chain fatty acids, which has widespread effects on health, including inflammation control, metabolic regulation, and gut integrity. So this fermented foods, other than the normal foods what we generally use, like idli, dosa and all, and breads are also fermented, but breads, once it is baked, we don't get that much of benefits. Whereas the recent fermentation foods which are helpful in the gut health is mainly kefir, yogurt, tempu, sauerkraut, kimchi, kombucha. All these fermented foods are fascinating and they give a lot of impact in the functional is very significant. As you agree that fermentation is a natural process that plays a significant role in the human culture and food preservation for thousands of years. These microbiomes consume sugars and salts, like kombucha is sugar, whereas kimchi and sauerkraut all with salt, it is being fermented. Even ginger can be fermented, that gives lot of gut benefits by fermenting ginger with sugar, gives lot of relief to the patients, and they convert this into alcohol, carbon dioxide and organic acids. And these examples which I said is sauerkraut, which is basically in Germany, kimchi in Korea, miso in Japan, and yogurt in different regions. But in India now, we are also, many of our patients are also started using all these for the gut benefits. Kefir is commonly being used. Many of my patients are using kefir, using the kefir grains. They are using kefir and they are fermenting it and they are using for their gut health, especially for the IBS patients and all, quite beneficial. Effect on specific bacteria is different types of dietary fibers such as soluble, insoluble, resistant starches and prebiotics. They impact the gut microbiota and significantly promoting the growth. So these are generally, short chain fatty acids are generally promoted by fermentation process. So they are, by promoting these bacterial species, different fiber types helps optimize the production of short chain fatty acids and metabolites that support various aspects of health. And these findings always important for consuming a variety of fiber types and foster diverse microbiome, and that can sustain short chain fatty acids producing bacteria and leverage for the health benefits. And the threshold of fiber intake, as we saw that in the menu that we are not able to achieve the target of our recommended allowance, so we may need to have supplements at that time. So dose dependent microbial effects essentially is very important in understanding the effects of fiber on gut microbiome and health outcomes. They help to identify the optimal types and amounts of fiber needed to produce meaningful changes in microbial composition, short chain fatty acids, and these are also beneficial, this fiber, higher fiber intakes, which also been important for the beneficial bacteria for health outcomes, and depends upon the fiber, close, dose, individual, and all these. When we are not able to supplement through the diet, we may have to give through the supplement through the diet. If we are not able to give, we have to give supplements in the form of inulin or FOS and all. Dietary fibers and diabetes, yes, they have got a very important role, because this fiber helps in regulating the glycosylated hemoglobin levels. In type 1 diabetes, the fiber intake can be 14 grams per 1000 kilocalories, or greater than 2 years of age, it should be plus 5 grams. That's a recommendation by the ICMR. It helps to reduce the HbA1c values. And we also commonly see that many patients have postprandial glucose high is seen. For them also, if you can give a pre-fiber before the meal, we can see a drastic difference in their postprandial blood glucose higher. And whereas in type 2 diabetes mellitus, the recommendation, ICMR recommendation is fiber is 40 grams per 2000 kilocalories, where we are not reaching the normal 30, how we are going to achieve the 40 grams per day. So in such cases, we may have to reach out to supplements to reach to our target of giving the fiber. This is the dietary fiber. It's a summary of major mechanisms associated with the glycemic control by the non-glycemic carbohydrates. You can see that the dietary fiber from whole foods, fortified foods, and other nutraceutical supplements, it gives an improved postprandial glucose control, and it also reduces the risk of type 2 diabetes mellitus. And we can see there is a delay in gastric emptying, modulation of the release of the digestive related gut hormones, the GLP-1 and CCK and PY, and there is delay of amylosis. All these are seen with an increase in the fiber in the diet and when the supplementation is given. So to conclude, I would like to say that dietary fiber offers a wide range of health benefits, making it a cornerstone of the balanced, health-promoting diet. Fiber-rich foods not only supports the digestive health, but fostering a diverse and balanced gut microbiome. And we have a lot of future research. Many researchers are here. You can all think about doing some understanding of specified microbial pathways and potential for tailored fiber consumption to prevent or manage diseases. And for those seeking specific health outcomes, personalized fiber intake can offer a powerful tailored approach in achieving a long-term health benefits. So always try to calculate the fiber intake and fiber, and then prescribe the diet as per the disease specification of the patient, so that we can embrace the dietary fiber as a key part of nutrition and incorporating personalized strategies individuals can achieve. Any questions? This is the reference which I have taken this presentation.
Thank you, Dr. Mumtaz ma'am, for the really insightful presentation. The floor is open for any questions or queries. Please do come forward.
Beta and alpha diversity, I'm not very sure, Manju. Where? This one. Gut microbial diversity, no? Okay. Okay. Here the fermentation of fiber by these microbes produces beneficial metabolites, including short-chain fatty acids, which have widespread effects on health, which including the inflammation control and metabolic regulation and gut integrity. So here the dietary fiber, all the different varieties of fiber is essential for cultivating the balanced, diverse microbiome, for helping to create a healthy ecosystem within the gut, which that benefits both individual and population's health.
There is one question on the chat box online. Shivani Sharma has asked, any protein powder suggestions? This question was posed a little before, so maybe even Mumtaz ma'am, I would like to ask you as well, if you would suggest any practical suggestions for, you said we have to give a supplement sometimes. What supplement do you generally suggest for fiber?
Fiber, since we have, I think, Maha in behind and she is showing his diafiber, then they are supporting us, so I think we can support them with diafiber. Even I have given for my diabetic patients, and I have found very good response with diafiber. One of my patients, she was having her postprandial glucose after breakfast was showing very high. But like when we see her food plates, we have identified that her vegetable intake, fiber intake was less, and she had minimal fiber intake of, she have only cabbage, beans, and one more carrot. These are the three vegetables she consumes, and her fiber intake was very less. So initially we found that her after breakfast her postprandial was going high. So we introduced this diafiber after pre-breakfast we introduced that. And then we in our diet we had prescribed vegetables and all in our diet, that is there. In addition to that we gave this, and we found that in 15 days we found there was a difference in her breakfast, like postprandial, after breakfast there is very good change we found. But then we identified that her after lunch, because she was on a CGM, so we could get her breakfast, lunch, dinner, whatever time we asked, she used to give her the blood sugar value. So we found that after her lunch, her postprandial was going very high. So then we shifted this diafiber from pre-breakfast to pre-lunch. One sachet pre-lunch we shifted, and we asked her to change her vegetables from her cabbage, carrot and beans to the other vegetables also, which she was very hesitant to add on the other vegetables, but she added the other vegetables, and we shifted the diafiber prior to her lunch. And we found that we were able to control her postprandial after lunch also. Now we are very happy, when she came to us, her HbA1c was how much, Anit? 9 was her HbA1c. 9 was her HbA1c, and it is now almost 1.5 months, and I think she has reached 7 now. Her HbA1c has reached that 7, and she is on continuous glucose monitoring, and we are mainly focusing, and she is on weight loss regime also. She lost weight also, and we are getting very good results with diafiber. So I am happy to say that, Maha. Yes, yes.
What is your take on that?
Yes, yes. That also we have checked. Yeah, that also we checked, that rice and bread. These are the two things we have checked. We have cooked and kept it in the not in the refrigerator, in the freezer compartment, and then we took out from the freezer compartment and defrosted and then reheated, and we asked the patient to have it, and we found there is difference in their values. We found that. We did with rice and bread. These are the two things we have tried. Freeze it. We have to not refrigerate it, we have to freeze it. Freeze it, defrost it and reheat it. Then the glycemic index reduces. Resistance charge. Maybe we can try all that. We have tested only rice and bread. We have not tried anything else.
Just keeping in the fridge will not do.
Normal, no, not normal rice. This patient was from UK, so they were using white rice. Whole wheat bread.
Just keeping in the fridge will not do. You have to keep in the freezer.
We asked the patient to keep it in the freezer compartment. They were quite happy. They didn't complain about anything because they over there, no, they don't cook. They have meal prep. We have online patients also. So not like us. They prepare for a week. They do their meal prep on weekends. For the whole week they prepare and keep it. So now what we tell these patients is when they cook and keep it, for single use containers they have to pack it and they have to freeze it. They have to freeze it and then take it out, defrost it and then reheat it. So that, what they have to do it from the freezer, they have to keep it in the refrigerator when they go for the work. By the time when they come back in the evening, it gets defrosted and then reheat it, so the glycemic index reduces. They don't cook on daily basis. Most of them don't do on daily basis, they don't cook.
Bread they can toast and have.
Yeah, they can toast. They can toast.
Rice, how we do? The second boiling should not be done.
Normally they boil, all these patients know where we have tried is all of them are microwavable ones, because none of them are who discard the water and do it. It's double, they didn't, I don't think they discarded the water, no? But when, I think when you microwave it, no, add little water at the base of the vessel with a steamer and then put the rice and then microwave, it will become softer. Not sprinkle. The containers has got that perforated lids are there, no? So on the bottom you have to place water and then perforated lid. On top of it place the food and then close the container and microwave it. So it becomes, any food, it becomes softer in consistency.
Online, Rakima C has asked, is resistant starch heat resistant?
Resistant starch is heat resistant.
Is it heat resistant? I think when you heat it, does it...
I think the process of using resistant starch is what just Mumtaz ma'am had explained. You have to freeze it and then thaw it, and then there is a process of reheating. It doesn't cause damage to the resistant starch when this process is done. It's a scientific way of taking resistant starch.
Right, I will note down on the chat.
Have you all tried the fermented foods? Any of the fermented foods to your patients? Kefir, kimchi, kefir.
I have advised this parangani.
Parangani.
Practically, do people do that, the parangani?
Parangani we have directions experience.
Okay, great.
Okay. I have tried carrots, cabbages, ginger I have tried. It's excellent for the gut health. It's ginger, what I did was 1 teaspoon of grated ginger, then 1 teaspoon of sugar, 1 cup of water, add to a bottle, and the evening stir it. Next day morning again add 1 teaspoon, same amount. For 3 days, consecutive days you have to. By the end of the second day, the bubbles will start, the fermentation process will start, end of the second day. So the bubbles will start on the bottle, and the third day, by the time it will be this big, wide open jar bottle, you should, glass jar bottles you should use. So it will be this big jars, it will be ready. And then third day, transfer that to the other bottle with a sealed top, and you can use that, maybe 50 ml or 100 ml. It is very good for gut health, and you have that starter there, no? So that starter, same starter, use it for the next day's preparations. And the other one is, when you put carrots, cabbages and all, when you put it, salt, when you put it, it should not come up. Normally when you put water, it will float on top, no? It should not float. So for that, what you have to keep is, you have to keep some weight, something on top of that, so that it should not come up. It should be fully dissolved in water. then only the fermentation properly it will happen. At minimum of 3 to 7 days you have to keep it, and every day you have to stir it. It's good to be added in your salads.
So there will be a lot of liquid on top. So that liquid we can use.
No, only the vegetable you are using.
Right. Thank you so much, ma'am.
Thank you.
So like I mentioned, there was a question on protein supplements. I think she has mentioned about in Chyle Leak. So Manju ma'am, can you just elaborate on this? I think she wants supplements on in Chyle Leak. What are the supplements we can use?
MCT based supplement is what is required. So present we had peptide based things which is having 70% MCT, and now we have a formula with intact proteins having 100% MCT. So that I think personally we can connect on the brands which was in the open platform, brands cannot be mentioned. So those can be used for a patient with Chyle Leak.
Right. Thank you so much, ma'am. As we move forward to the final, now before we conclude, we have a special introduction on Dia Fiber by Mr. Prakash, Area Sales Manager, Nestle.
First of all, thank you very much for giving the opportunity to interact with all of you and to participate in the A.E.D.A.N program. So really evidence-based approach what all of you are leading through. So it's a right sign how we can able to take the nutrition to the next stage. Thank you very much. So myself, Prakash, as she has mentioned, and being working with the organization for the last 17 years, and our purpose of being as a company to provide a maximum nutrition solution to the patients, so that how we can able to partner along with you to provide a better solution to your patients. So recent there are some kind of developments with effective from August. So you must be seeing that many of our representatives are meeting you by talking about Dr. Reddy's and Nestle Health Science. So there was a purpose behind that. So Nestle, as all of you are aware that it is a very scientifically formulated company with a lot of scientifically evidence products. And also the Dr. Reddy's, one of the Indian multinational pharma company. So both the companies are decided to join together to form a joint venture. So that is the purpose we are here. Now the company name is Dr. Reddy's and Nestle Health Science. So the experience, the power of our innovative nutrition solutions, and join us as we embark on a journey of towards the healthier tomorrow. That is our major purpose. Now you can join the force to shape a brighter tomorrow through a portfolio of nutrition what is available with us. Now Nestle, we started the nutrition solution from the birth. As well, we progress towards the disease-specific nutrition support, and by joining with the Dr. Reddy's, now we have increased our portfolio, and you can find many of the solutions are approaching to you for your patients' benefits. Not only that, now coming forward in the coming months, we also trying to introduce in Indian market the VMHS range, vitamins and mineral health supplements. So it is an additional portfolio, and many things are coming in front of you. So you must be seen that many statements like 75% of ICU patients experience enteral feeding intolerance, which leading to the patient's malnutrition and delay and is increased cost. So what we offer through the Nestle and Dr. Reddy's now, like Peptamine, many of you are using, thank you very much. And this is a complete diet and a semi-elemental diet, so with MCT formula. So any patients required the MCT preparations as well we to feed the patient as much as early as possible. For those solutions you can make and consider the peptamine. Additionally, now we also introduce a new preparation in the market with in the name of Celivida E.N, which is also 85% MCT rich formula, which a comprehensive formula with customized dilution and clinically trusted and tested. So you can find that MCT is about 85%. So many of the discussions, Chyle leaks and patients with pancreatitis, multiple patients really need these kind of solutions you may can consider, and also supported with the carnitine and taurine along with a combination of the protein that is also best quality of protein, whey protein concentrate. And also can be customized to different patients, can be isocaloric in nature or calorie dense. So multiple calorie density we can able to prepare. May the patient can need a calorie restricted diet. So the same formula we can prepare in a calorie restricted formula, or we can able to prepare the formula as isocaloric so that we can increase the volumes. And also talking about some of the customized diet and the importance of fiber, Madam Dr. Mumtaz has talked about. So the need of fiber is increasing, or we can say that our usage is coming down because of our dietary habits. So that also leading to multiple problems. So here what we are offering in the name of the role of fiber for optimizing the postprandial glucose levels. So we introduce August month, we introduce a product in the market for the PPG control in the name of Celivida Diafiber. So this Celivida Diafiber, which offer the postprandial glucose control and additionally a 3x fiber choice and offering the satiety. So the patient one sachet can able to get around 9.2 grams of fiber. So is clinically proven, well studied in, and especially we talk about the study we conducted in Dr. Mohan Diabetic Research Foundation. So very clear proven results are there. So you may can able to try these kind of solutions. So we are using a special type of fiber, fibrosol 2. It is a resistant maltodextrin which are importing from Japan, which having a proven benefits in control the fast blood glucose levels and improve the intestinal function and metabolic syndrome, also increasing the satiety levels of the patients. So this is one product which we have recently introduced. Additionally, many of the patients also having some kind of a constipation and diarrheal episodes. For those patients, we have another fiber which is available, resource fiber choice. This is also the ingredient is like the type of fiber what we are using in the partially hydrolyzed guar gum, which is also available in small sachet. So it depends on the patient's need. 1 to 2 sachet can be incorporated in each day of the patients. So we have multiple nutrition solutions that is we have displayed back to you. So while you are having your high tea, you may can experience the kind of solution what we are currently offering, and we will reach out to you with multiple other solutions in the coming months and also future with a complete portfolio of solution. Thank you very much and wish you a happy Diwali.
That brings us to the final part of our program. I would like to invite Ms. Lakshmi S, Social Media In Charge, A.E.D.A.N, and Dietitian KVM Hospital, Cherthala, to deliver the vote of thanks.
Good afternoon, everyone. As we come to the conclusion of this insightful and impactful clinical nutrition update, it's my honor to deliver a vote of thanks on behalf of this organizing committee. First and foremost, I extend our deepest gratitude to our esteemed Chief Guest, Dr. Fadl, and for the scientific session. And a heartfelt thanks to our distinguished speakers, Dr. Manju P. Josh and Dr. Mumtaz Khalid Ismail, for sharing your expertise and knowledge. Your presentations and discussions have been incredibly informative and engaging. And I also thank Ms. Drishya Dev and Ms. Ansi Vijay for the comprehensive case study presentation also. And also I extend my gratitude to the Executive Committee A.E.D.A.N for your tireless efforts and meticulous planning. And I also extend my appreciation to Dr. Reddy's and Nestle Health Science for your support, and it makes this event a successful one. And special thanks to all our winners for your active encouragement and also participation. To the technical support team, thank you for ensuring all our sessions both offline and online. Lastly, I would like to thank the hotel staff for their excellent service and hospitality, and your efforts have made everyone feel comfortable and welcome. In conclusion, thank you once again for this active participation and encouragement, and to make this event impactful. For an impactful experience. And have a great evening. Thank you.
Thank you, Ms. Lakshmi. As we conclude today's gathering, let us take a moment to appreciate the collective knowledge and shared experiences that have enriched our understanding. Thank you all once again for being part of this event. Please join us for high tea and enjoy the refreshments prepared. Myself, Fiza Nawaz, Editor and Executive Committee Member, A.E.D.A.N, signing off. Have a wonderful evening.